Okay, good evening, students. Today we are going to do on pediatric pneumonia, followed by asthma. So it's a very good topic from respiratory case point of view. I'll try to be as concise as possible and followed by the important questions that might come. Okay. So to start with, Manju, 1 year old, 1 month old female child, resident of Sadar Bazar, Delhi. So the first will be your demographics, of which age is important. I will come to the later on. Depending upon the age, the type of organism will vary. So this is the age group where viral infections are very common, up to 5 years. Okay, 6 months to 6 years, you have more viral infections common. Informant, make sure the mother is giving a reliable, make sure mother is giving the history, so it's going to be reliable. And try to use the patient's own words. Okay, patient presenting with complaints of fever and cough since 6 days, and fast breathing since 4 days, reduced oral intake since 1 day, and increased irritability since 1 day. So use patient words, don't use technical words like tachypnea. Similarly, the words like dyspnea, which is a patient's own awareness. For a 1 year old child, it's not possible. So patient's own awareness, all you don't try to use. Okay. And coming to the history of presenting illness, child was apparently well 6 days ago when she developed a fever. The temperature was recorded 102 to 103 fever Fahrenheit. Fever was not associated with chills and rigors. There was no rash, no diurnal variation, and somewhat relieved with medications like antipyretics, and child well in between episodes. Okay, I'll keep reading the presenting complaints fully. Cough was wet as there was some sounds noticed by the parents. Non-paroxysmal, non-spasmodic, no diurnal variations, no aggravating factors, and not associated with any post-tussive vomiting. Cough was still persisting in spite of medicines, taking medications. Child has fast breathing for the past 4 days and increasing, but no chest retractions according to the mother, and not relieved promptly by medicines. No history of worsening with feeding, the fast breathing. No suck rest suck cycle, no forehead sweating. History of noisy breathing present, but not able to characterize. Mother is not able to characterize the noisy breathing. Reduced oral acceptance and increased irritability since 1 day. So here, chills. Chills is something which is subjective. Don't try to use that in this presenting complaint. So chills will not come. Rigors may be present. And the presence of fever suggests that there is probably some infection or at least some inflammation is going on. And if there is any rash, it could be a viral fever because viral infections are common. So try to elicit history of a viral rash and try to characterize if it is not measles. You have the maculopapular rash coming from the head to foot with conjunctivitis. Make sure it's not a measles rash because the pneumonia, staph pneumonia is very common with measles. And it cannot be an asthma because usually asthma will be afebrile. And coming to cough, the gurgling sound, wet cough or dry cough, you can differentiate. And remember, children up to 5 years do not expectorate. They swallow the sputum followed by vomiting. So the post-tussive vomiting or the post-cough vomiting is an equivalent to productive cough. So if the child keeps on vomiting often with cough and whatever vomit is mucoid, it is an equivalent to expectoration. Diurnal variation, very often we talk about diurnal variation. If it is nocturnal, probably it is asthma where you have diurnal variation. And paroxysmal event. Here it is non-paroxysmal. Paroxysmal means sudden. Sudden event in a child, they try to ask you because they want that it could be a foreign body. They want you to tell that it could be a foreign body. And regarding fast breathing, remember the moment there is fast breathing, instead of the URI, it has gone to the lower airway involvement. Okay, so there can be running nose, which is probably upper airway, but once you have fever, running nose, cough, and fast breathing, then the lower airway, especially the parenchyma, is involved. And also, you should remember that always, not always, fast breathing is equivalent to respiratory tract. they will ask you the differential diagnosis. It could be a respiratory, it could be a cardiac, it could be metabolic acidosis, it could be raised ICT resulting in hyperventilation, and sometimes very trivial causes like fever can cause tachypnea or fast breathing. Even a nasal block, children breathe through the nose, small babies breathe through the nose, so nasal block itself causes respiratory distress. And regarding noisy breathing, they might attempt to ask you, sometimes you can have audible noises. It could be a stridor. They might ask you, what is it? It's a inspiratory sound, stridor, due to laryngeal involvement, stridor. Okay. Wheeze, it's an expiratory noise audible by the parents. Okay. It's an expiratory phenomenon, wheeze. And sometimes grunting, where the baby breathes against a closed glottis to prevent collapse of the alveoli. They expect you to tell these words. What is grunting? Grunting is the noise produced when the baby breathes out against a closed glottis to prevent the alveoli from collapsing. So that is grunting, which is suggestive of parenchymal lesion. Okay. And reduced oral acceptance, we have asked because we need to understand whether it is severe enough needing hospitalization or not. Okay. And after the presenting illness, you should be able to say that it is an acute onset infection. It is an infection because fever is there, acute onset, less than a week duration, and probably because of the fast breathing, the lower respiratory tract is involved. Okay, and does it deserve hospitalization? Yes, there is severity is high, reduced oral acceptance is there, and irritable child is also irritable. Okay, and coming to the negative history, no history of running nose, ear pain, and ear discharge. No history of loose stools, vomiting, abdominal pain, and rash. Here, why we are asking? Because we want to differentiate viral infection from the bacterial infection. Viral infection usually is multi-systemic. So it involves the upper respiratory tract infection, which includes running nose. It can even involve the ear discharge, ear pain, and also it can involve the GI system. So loose stools, vomiting, abdominal pain. So it can involve the multi-systemic. Okay, and viral often can present with some sort of rash, especially remember the measles rash, because the pneumonia, which is going to be serious type, if it's going to be measles rash, okay, the staph pneumonia is going to be very serious enough. No history of failure to gain weight or there is any weight loss. So not only weight loss, failure to gain weight is also important. No evening rise in temperature, because if there is a fever history of more than 2 weeks, so here it's only 6 days, more than 2 weeks, along with respiratory symptoms, along with maybe an history of not gaining weight, we should suspect tuberculosis here. They will always, in the respiratory case, they will always come back to tuberculosis. So when will you suspect tuberculosis? So it's going to be a longer duration of fever plus respiratory symptoms, plus this not only weight loss, 5% weight loss, even failure to gain weight is also important. Okay. And no history of cyanosis, lethargy, altered sensorium, convulsions, vomiting, okay. So here these are all symptoms suggestive of complication. Okay, so the pneumonia is severe enough to cause cyanosis. There is a lot of hypoxemia and carbon dioxide, so resulting in lethargy, altered sensorium, and convulsions, or the infection has passed on to cause meningitis and septicemia. Okay, so you have to ask questions related to complications in the negative history. Coming to history of care, no history of any previous nebulization or hospitalization in the past. No history of earlier treatment, no history of any form of allergies in the past. It could be skin allergies or food allergies. Okay. Why these recurrent episodes are asked? Because very important is the asthma. It is characterized by recurrent episodes of respiratory symptoms as well as cough requiring nebulization, which madam will be explaining later on in the other case. Also, recurrent episodes of cough with fast breathing needing hospitalization suggestive of real pneumonitis, recurrent pneumonias. Always think in terms of cystic fibrosis, immunodeficiency, or sometimes congenital heart disease like VSDs, or if the child is a CP or any anatomical malformation like tracheoesophageal fistula is there. So aspiration is common, causing recurrent LRA. So whenever a child has 2 episodes in 6 months or more than 3 episodes for the whole lifetime, we call that as recurrent episodes. Okay. And spacer history. Try to ask in the past history regarding the treatment. Also in treatment history, whether spacer was used, whether any preventive treatment was used or not. Then comes history of contact with TB. There is no history of contact with any person with tuberculosis. Very important in respiratory case. And you need to understand that in the recent 2 years, they ask about contact history. In the recent 2 years, anybody had any TB? They don't come up with straight away they had TB. You have to ask whether any family member with chronic cough, whether anyone died due to respiratory symptoms, and it doesn't stop with household contacts, close contacts. So even here the child is 1 year, so even if a child goes to school, so even in the school also close contacts is important with TB definition in the last 2 years. Okay. And treatment history: prior to admission, oral medications were given. After admission, IV fluids and some medications, probably antibiotics, have been given. So here the history is important because to choose the antibiotics. If recently oral medication given and child is not responding, maybe we have to step up the antibiotics. Okay. And coming to antenatal history, it has been it's not much important. So just say uneventful, and it was a booked case, and immunized. Mother was immunized. Make sure that proper care was given antenatally, and it was uneventful. And finally, in the natal history, it's going to be a full term normal vaginal delivery, 3 kilogram, immediately cried after birth. And make sure that everything went normal. So no NICU admission, and breastfeeding was started within half an hour. That says that everything was fine. Okay. And postnatal history was also uneventful. If any jaundice was there, any phototherapy was given, anything, you have to mention that. Otherwise, no need to elaborate as in cerebral palsy, where we elaborate in first trimester, second trimester, third trimester. Okay. Okay. Coming to the nutrition history. So any pediatric case, try to take your nutrition history, development history, immunization history in detail. Okay. Child was breastfed till 1 year, exclusively breastfed for uh, here 8 months. Okay. Then semi-solids were introduced, and child was breastfed till 1 year. After that, they have stopped breastfeeding. And at present, the child consumes about 650 calories and around 15 grams of protein, as against the expected 1000 calories and 20 grams requirement. So you can even give a deficit. How much is the deficit? So that would be nice. Okay. So the nutritional history is important. Suppose breastfeeding is also going, you just say in addition to 650 calories and 15 grams of protein, child is also taking breastfeeding. Okay. And immunization history, make sure the major vaccines have been given or not. So child has received DPT, hepatitis B, polio drops, and measles vaccine at appropriate age. The mother may not come up with this, but as per national immunization schedule, you can even say like that. As per national immunization schedule, the child has been given vaccination, and the last vaccination was given at 9 months of age. So it is understood that they have given all these vaccines. And nowadays, in national immunization schedule itself, the rotavirus is also given, and in some places pneumococcal is also given. And recently pneumococcal has been made mandatory for all over India. It's going to come very soon. Okay. And what they might ask you about questions about related to pneumonia. So one is BCG vaccine. Definitely they will ask you about BCG vaccination. The most important question they will ask is, if the child has been BCG vaccinated, so will the child not get TB? So the answer is no, they will get TB, because BCG doesn't protect from all forms of TB. Only mainly the severe forms of TB it protects. So the mild pulmonary tuberculosis, all it may not protect. It protects mainly against the miliary forms, meningeal forms of tuberculosis. Then they will ask you about the importance of pneumococcal vaccine, the schedule, H influenza vaccine, measles vaccine, and sometimes they might even ask about the influenza vaccine. So keep that with the schedule and route, etc. Then developmental assessment: child is able to stand without support and trying to walk, able to speak 3 words, wave bye bye, play peekaboo game. So whatever at this age child is doing, you just tell those milestones and say that the child's development is appropriate for age. Okay. In family history, the child is born out of non-consanguineous marriage, no history of similar complaints in siblings or parents, no history of asthma, allergy, or tuberculosis in the family. Make sure that there is no family history, make sure that everything is fine, or if they are suffering from anything, you just mention, especially the allergies run in families, okay? Socioeconomic history, very important. So here lives in a Pakka house and belongs to lower middle socioeconomic status according to the modified Kupusamy scale. Main important is consider about overcrowding. Is there overcrowding present? Suppose you have more than 3 persons, family persons for 2 room, it's considered overcrowding. More than 5 for a 3 room, then it is overcrowding. Okay. And here overcrowding is present and father smokes at home. He's a smoker. So children are exposed to passive smoking. That is also a risk factor. And mother is a housewife and father works in a shop as salesman. Mother's literature is 5th grade and father 10th. So the education status is very important. So they may not be so aware and you have to give a lot of education and counseling to follow the complaints with treatment. Okay. So the summary of the history is here is a 1 year and 1 month old female child resident of Sadar Bazaar, Delhi, presented with a short 1 week history of fever, cough, fast breathing without coryza, and reduced oral acceptance and increased irritability. Okay, there is no history of similar complaints in the past, no history of nebulization, and no history of recurrent infections in the past. Analysis is child presented. So this they might ask you, what do you infer from it? So I infer that it is probably a respiratory tract infection. It is an infection, and probably it is a lower respiratory tract infection in view of the faster breathing, and it's a short acute history. So infection is the etiology, and since there is no viral prodrome, there is no such as coryza or rash or diarrhea, etc. The viral disease is unlikely. It doesn't look like a viral disease. Okay, so the my provisional diagnosis is a lower respiratory tract infection. Okay, and probably it could be pneumonia, bronchopneumonia, pneumonia or bronchopneumonia, either of it. And sometimes complications like pleural effusion also could be there. So I would like to even exclude complications, and I would like to examine the respiratory system. So that will be your provisional diagnosis. And coming to the examination, child is conscious, irritable, and not comfortable. Very important whether the child is comfortable or not. Okay, whether the child is irritable. Irritable is a sign of hypoxemia. So make sure that the child is comfortable, not having any distress. Okay, otherwise you mention it. Then comes the vitals. So respiratory rate is 68 per minute, and it is abdominothoracic, and there are subcostal retractions present, but no flaring of Alanisi, no accessory muscles in the neck are involved, and there is no head bobbing. Very important to know how severe is the respiratory problem. So here they will ask you about the IMNC criteria for fast breathing. Okay, so less than 2 months, so more than 60 is tachypnea. 2 months to 1 year, more than 50 per minute is tachypnea, and more than 1 year, more than 40 is considered as tachypnea. So any tachypnea as per IMNC is pneumonia. Retractions, then it's going to be pneumonia. So here subcostal retractions are there, so it's going to be severe pneumonia. And if there is going to be flaring of Alanisi, accessory muscles are involved, and even head bobbing is there, then the pneumonia is very serious sort of infection, might need immediate ICU admission. Okay, and the pulse rate is 110 per minute. Pulse is regular, rhythmic, good volume, no radial or radiofemoral delay, and CRT, very important, it's less than 3 seconds. So the child is not in shock. And remember, all these parameters may vary because of the fever itself. So here fever is 1 or 2. So for every 1 degree rise in temperature, they will ask you 4 RR will increase and 10 pulse rate will increase. So you have to subtract for that. So here 3 4s are 12. So even if we subtract 12 from this, still it will fit with the tachypnea criteria. Okay. And coming to the anthropometry, very important. For less than 5 years, we are going to use the WHO growth charts. More than that, IAP growth charts. You have to give your interpretation. So here weight is 8 kg. So it is just above the third centile. For a 1 year, we want at least 9 kg plus. So it is just greater than third centile. So it is just above the criteria for undernutrition, or else we would call the child as undernutrition. Then height is 76 centimeters, so it is around the 50th centile, so it is normal. Otherwise, we would put under stunting, less than third centile, stunting. And head circumference, it is in the third to 50th centile, so it is normal. And weight for height, very important. Weight for height, it is between the first and the third centile. So it is below the third centile. So it falls under the moderate acute malnutrition. If less than one centile, then it is severe acute malnutrition. So here it is moderate acute malnutrition. So which means recently there has been some problem with the feeding issues. So in addition to the all the treatment, at the end while discharge, you have to also address the nutrition issues also. Okay. And is also 11 to 12.5 centimeters. So above 12.5 is above 13.5 is fine. So here 11 to 12.5. So it also suggests that it is moderate acute malnutrition. Less than 11 is going to be severe acute malnutrition. Okay. So use the WHO growth charts to tell your interpretation. Then head to foot examination. So icterus pallor cyanosis. So here mild pallor is there. No cyanosis, which means because of the respiratory distress, the cyanosis has not developed. Otherwise, it's going to be a serious issue requiring intensive care. No icterus, no lymphadenopathy, especially for tuberculosis, lymphadenopathy is important. No clubbing, no edema. Clubbing suggests that there is a long-standing severe disease, especially suppose you have a bronchiectasis, you get clubbing. And cyanosis, if the disease is going to be severe, you are going to get cyanosis. And in addition to this, from head to foot, all the vitamin deficiencies, you try to tell about that, no signs of vitamin deficiency. And related to the respiratory system, the ears are important, no discharge from the ears. Mouth is important, how is the throat and tonsils, and is there any cleft lip or cleft palate, because that can cause aspiration. Dentitions are fine. Make sure that you talk about the BCG mark. The BCG mark is present, and the BCG mark gives protection from severe forms, which we have already told. Sometimes Mantoux mark might be there in the arm, where you have to look into the induration, not the erythema. More than 10 millimeter is considered significant. It only suggests that the child has been exposed to prior to TB bacilli. Okay. Okay, coming to the respiratory system examination, very important part here. Wait a minute. So you start with nose. Do not straight away go with inspection. Start with the upper airway. Nose is normal, no flaring of the ala nasi. Then go to the oral cavity. Oral cavity and throat tonsils are normal. Inspection, start with the trachea. Trachea is in the midline. The apical impulse you have to talk about. And the chest shape is circular or normal in shape. There is no use of accessory muscles, but some subcostal recessions are present. No nasal flaring is present. And no scars, sinuses, or veins over the chest seen. Apical impulse I am not able to make out in the inspection. Okay. Then finally you look into the movements. Movements appear decreased on the right side. Okay, so this will be your inspection. You can also comment in the spine also from the looking at the back. How is the back? Any kyphoscoliosis is there or not? Then comes to the palpation, where you are going to confirm about the tracheal and the apical impulse. Okay, we need to show there is no mediastinal shift. Okay, so apical impulse is in the fourth intercostal space along the midclavicular line. Usually for children, it's going to be in the fourth intercostal space. Then trachea is in the midline. Okay, and chest expansion is decreased on the right side. So you're going to confirm by the palpatory method that the chest expansion is decreased on the right side. And you look into the vocal fremitus, you cannot ask the child, so it may not be done. And anyhow, in auscultation, you're going to confirm with vocal resonance. So vocal fremitus could not be done. You can say no issues. Then on percussion, the note is impaired or dull over the right mammary, right infraaxillary, and right infrascapular areas. Okay, so there is a dullness, impaired dullness. It's not stony dull, it's impaired dullness over the right mammary, right infraaxillary, and the right infrascapular areas. And the cardiac apex is normally placed. Okay, cardiac apex is normally placed in the fourth intercostal space along the midclavicular line. On auscultation, I'm able to make out, first you talk about the bronchial breath sounds, if any, on the right mammary, right axillary, and the right interscapular areas. Occasional crepitations are also present. No other added sounds. And vocal resonance is increased in those areas. Vocal resonance is increased. So bronchial breath sounds are heard. some crepitations are made out, no other added sounds are there, and vocal resonance is also increased in the same areas. So coming to one by one, so apical impulse and tracheal position is very important. As I already said, it says that there is no mediastinal shift. If there is going to be a pneumothorax or pleural effusion, the apical impulse and tracheal position is automatically going to shift to the opposite side. Okay, and trail sign suggests it's nothing but what is trail sign. So the sternocleidomastoid mastoid looks prominent on the side where the trachea moves. So that is trail sign. So it's an inspectory finding. Okay, and this severe pneumonia and very severe pneumonia, on inspection, you try to make sure the accessory muscles, the nasal flaring, the head bobbing is there or not. So these things suggest that it's not just a pneumonia. Pneumonia means only the fast breathing. Once the other things like this retractions are there, subcostal retractions, nasal flaring, head bobbing, which suggests a severe pneumonia. Okay, and child needs immediate intensive care management. And decreased movement on the right side, whenever movement is decreased on one side, the pathology is on that side. So remember that whenever you talk about movements decreased on one side, it means that the pathology is on that side always. Okay, and the chest expansion is decreased here. And with regards to consolidation, remember this is all the findings which you have told is suggestive of consolidation or pneumonia, which will have a dull note on percussion. It's going to be dull note, and your vocal resonance and vocal fremetus is going to be increased, and you are going to get bronchial breath sounds in the consolidation. But with regards to pleural effusion, where it's going to be stony dull on percussion, Remember, it's like a curtain. It's like a curtain, pleural effusion or pneumothorax. It's like a curtain in the pleura, and nothing is going to be heard. So your breath sounds are going to be diminished. The vocal resonance, vocal fremetus is going to be decreased in pleural effusion and pneumothorax. But on percussion, in pleural effusion, it's going to be stony dull, and in pneumothorax, it's going to be hyper resonant. Okay, so remember the differences. And in bronchopneumonia, it's like a diffuse bilateral involvement. So you will be hearing, in addition to the crepitations, wheezes also will be involved because the bronchus is involved, and it is going to be a diffuse. So both the lungs you will have findings. It will not be localized to one side. So rhonchi will be there. So these are the important findings. In addition to the abdominal examination is normal, as abdomen is soft with no tenderness, no organomegaly. Sometimes liver can be palpable, especially where you have a hyperinflated chest. So you can have some amount of liver being palpable. Cardiovascular system examination is normal, as S1, S2 is heard normal and no murmurs are there. And central nervous system revealed that except for the irritability, otherwise everything is fine. And make sure that there are no meningeal signs, because sometimes the pneumonia can spread causing meningitis. Okay. So the summary of the findings are, here is Manju, 1-year-old female child presented with fever, cough and fast breathing for the past 4 to 6 days with no contact history for tuberculosis. On physical examination, there is fever, tachypnea with subcostal retractions, decreased movements on the right side, along with dullness on percussion on the right lower chest region, infraaxillary and infrascapular areas, and bronchial breathing on the right side, and occasional crepitations are seen. So my provisional diagnosis, it's a lower respiratory tract infection, probably severe right lobar pneumonia, etiology probably being Streptococcus pneumoniae with moderate acute malnutrition. Okay, sometimes maybe you may not say exact etiology, they might be offended. You can just stop with lower respiratory tract infection. Probably it is a right lobar pneumonia with moderate acute malnutrition. And as per IMNCA criteria, you can say that it is severe pneumonia. Okay. So investigations, what investigations you are going to do? CBC, peripheral smear, CRP, and blood culture. But blood culture, you may not get so much yield. And CBC, you will have a neutrophilic predominant leukocytosis. Okay. And peripheral smear might show the toxic granules suggestive of bacterial infection. CRP may be elevated, but blood culture yield is low. And chest X-ray will show the air bronchogram, and if pleural effusion is there, obliteration of the costophrenic angles can be seen. Mantoux test is one important test to rule out the prior exposure to the TB bacilli. So remember, the induration is important, not the erythema. And the horizontally, you have to check whether it is more than 10 millimeter. And if possible, if sputum is there, if then you can do the gram staining and the culture. Most important investigation. Coming to the important discussion points, very important in respiratory, they will ask you this IMNCA flowchart. Remember this IMNCA flowchart. Understand the general danger signs. Is the child able to drink or breastfeed? Does the child vomit everything out? And does the child have convulsions? And is the child lethargic or unconscious? If anything is there, any danger sign is there, automatically it's going to become a very severe disease, pink category, and immediate referral. Okay, so these are the danger signs, pink category, immediately refer urgently to the hospital. Then you count the breaths for 1 minute and look for any chest indrawing, see whether any stridor is there. And as per the IMNCA criteria, I said for 2 months to 12 months, it's going to be 50 breaths per minute. And for 12 months up to 5 years, it's going to be 40 breaths per minute for the tachypnea. So if any fast breathing is there, it's going to be pneumonia. Give amoxicillin for 5 days. If there is going to be fast breathing plus chest indrawing or stridor, then it's going to be severe pneumonia. If there is going to be general danger sign also, then it's going to be very severe disease. So give an injectable and immediately refer urgently to the hospital. Okay. And some questions about community acquired pneumonia. Hospitalization. So remember, just fast breathing is not enough. There need to be a lot of retractions and accessory muscle involvement, head bobbing, ala nasi flaring, grunting, and lethargy and shock. These are all suggest the indication for hospitalization or very poor intake. Then SpO2. Saturation, pulse ox if available, SpO2. If the saturation is less than 92% of room air, then it is also indication for hospitalization. Important etiological agents, remember bacteria, it's going to be Streptococcus pneumoniae, Staph aureus, and H influenza. H influenza has become rare because of the vaccination. Pneumococcal vaccination, if you have taken, the pneumonia is also going to be a bit less incident. Staph aureus, yes, it's always there in the, especially when there is empyema, the empyema pus, then it is Staph aureus. And viruses, very common etiology, especially in the 6 months to 6 years, RSV, influenza, and para-influenza. And more than 5 years, school-going children, atypical organisms like mycoplasma and chlamydia, remember that. Staph aureus, specialty is, remember empyema, remember Staph aureus. Nematociles, remember Staph aureus. And as a complication for measles, you get Staph aureus. H influenza, very common for less than 3 years, and that also because of the immunization, it has come down. And atypical organism specialty is they have few physical signs. It's called walking pneumonia. They will be comfortable, but once you take the chest X-ray, you realize that there is a huge bronchopneumonia. So atypical organisms, few physical signs alone will be there. Treatment, oxygen, IV fluids, and nebulization. If wheeze is there, go for a nebulization or antibiotics. Antibiotics, do not say any hi-fi antibiotics. It's going to be amoxicillin or cotrimoxazole for 5 days. And if you suspect staph, then you can add amoxiclav or amoxicillin plus cloxacillin. If the child needs admission, still it's going to be IV ampicillin or IV amoxiclav. If staph you suspect, it's going to be amoxiclav or cloxacillin. Still not responding, then only go for the third generation cephalosporin. Don't go straight away for ceftriaxone. Coming to tuberculosis discussion points. Now it's not RNTCP, it is now called NTEP, National TB Elimination Program. Okay, previously it was only smear microscopy for AFB. So sputum you do microscopy for acid fast bacilli, but now we have moved on to molecular methods. So you have to tell all this: rapid nucleic acid amplification test, NAT. So rapid NNACC. So 2 hours you are going to get the report. So it can be TrueNAT or Gene Expert. It's a higher sensitivity than your just smear microscopy. And one advantage is rifampin resistance will also be said in that itself. Okay. And nowadays we also do, if rifampin resistance is seen, or if the patient comes after discontinuing defaulter, then you can also do the line probe assays to test for rifampicin, INH, and other second line drug resistance. So now here is a possibility where you get the values for resistance very easily. So there is no need to have a separate category for defaulter. So now, as per NTP, there is only one category, okay, that I will tell. So now the mandatory is nucleic acid amplification test, that is gene expert or TreeNet, for every patient where a biological specimen can be produced. So if there is a biological specimen, you have to submit for NAT. So universal drug sensitivity testing. So once NAT is applied, since rifampin resistance is automatically part of NAT, so universal drug sensitivity testing is also being done. And daily drugs, previously it was alternate day drugs, now it's daily drugs with fixed dose combination for children. So it's going to be a fixed dose, there is no weight per kg basis, kg per day basis. It's going to be a fixed drug dose, and you have 6 weight bands. If the child falls in that weight band, that fixed dose combination is going to be given. And the dosage, remember, HRZE, okay, for 2 months, followed by HRE for 4 months. Previously, when we used to read, there was no ethambutol. So now for maintenance, HRE is also being given for 4 months. Plus, they suggest to add pyridoxine because of the INH neurotoxicity. So 10 mg per day pyridoxine can be given. And for preventive treatment, suppose there is a family member who has household contact, has TB on treatment, you have to give for a child less than 5 years. First, find out that there is no TB in the child and give INH 10 mg per kg per day for 6 months. So that is the preventive therapy. So this flowchart need not remember fully. So you need to know when will you suspect tuberculosis. So persistent fever for more than 2 weeks, very important. So the fever should be more than 2 weeks. If the cough may or may not be present for 2 weeks, weight loss of 5% may or may not be present, or failure to gain weight for the past 3 months. These are all extra, but most important will be fever should be present for more than 2 weeks to suspect TB, along with maybe cough may be present for 2 weeks, weight loss may be present of 5%, or the child is not gaining weight for the past 3 months despite adequate nutrition. And with or without contact, still contact may or may not be present. And the first step is do a chest x-ray. If chest x-ray is suggestive of TB, then go for the NAT, go for the true NAT or gene expert. If NAT is positive, straight away start the treatment. If there is non-specific shadows not suggestive of TB, then give a course of antibiotics, then again check the chest x-ray, still it persists, then again you submit for NAT. If NAT come positive, then give the ATT. So this is the protocol for TB. And remember, since you are in the COVID era, they will definitely ask some questions about COVID-19 in children. So COVID-19 is the disease caused by the virus SARS coronavirus 2. It doesn't affect much the children. It's going to be a mild infection. Most often, it might affect the immunosuppressed kids. Presentation will be just like any other viral infection. They present with cough, fever, gastrointestinal symptoms, running nose, sore throat, nasal congestion, rash, conjunctivitis, loss of smell. It's just like any other viral infection, viral URI. And during the time of pandemic, you have to suspect, that's all. And do the RT-PCR by nasopharyngeal swab and oropharyngeal swab, which is a viral nucleic acid, where we detect the RNA. And some laboratory parameters suggestive of COVID is lymphopenia and increased inflammatory markers like CRP, ESR, procalcitonin, increased CPK and SGOT, SGPT, LDH and D dimer. So some inflammatory markers and CPK and SGOT, SGPT, LDH and D dimer may be increased. Imaging chest X-ray, remember to talk about bilateral ground glass opacities. Supportive care, not much available, just oxygen if too much distress. Only approved drug available at present is remdesivir. Vaccination is also not approved for children so far, and it's at present only for the 18 years above only possible. So vaccination also not possible. And they might ask you maybe just one point, if you are good enough, you're talking a lot of good. So multi-system inflammatory syndrome for COVID, which is similar to Kawasaki disease, where you have fever with inflammation with multi-system involvement. So fever will be there, inflammatory markers will be there, CRP, ESR and ferritin will be elevated, okay, and multi-system involvement. So you can have rash, you can have conjunctivitis, you can have diarrhea, okay. But most important will be a history of SARS-CoV infection recently within the 4 weeks. At present, the RT-PCR will be negative, but recently there will be a history of infection. It could be either the child would have suffered with a COVID, or it could be a contact with a strongly contact with a COVID household contact, or at present the antibody may be positive. So this is about COVID-19. I think I will stop with the presentation. So mainly in RS they will concentrate especially the IMNCI. So remember to read about the IMNCI criteria. They will ask you a lot of clinical findings. So okay, so they will ask you, how will you say it as consolidation, how will you say it as pleural effusion, pneumothorax. So the clinical interpretation, they might ask you a lot of questions, and the IMNCI criteria again. Okay, thank you. Kavya?